today, Paula Archer and Jennifer Goins. Paula is a member of BKD's Healthcare Performance Advisory Service Division. She is a health information professional with greater than 25 years of experience in coding, clinical documentation, risk adjustment, and compliance. Paula assists healthcare providers in increasing their net revenues through improved mid-revenue cycle operations and revenue integrity practices. She's a coding subject matter expert with consulting experience in MSDRG, ICD-10, CPT, and merging of HIM coding and CDI professionals. Prior to joining BKD, Paula held leadership positions at 2 large health systems in Arkansas. Her background includes utilization review, revenue integrity, coding compliance, and physician education. Paula provides education in coding, CDI, and physician staff on current and changing regulatory guidance and revenue cycle topics. She's a member of Healthcare Financial Management Association and the American Health Information Management Association. Paul is a graduate of Arkansas Tech University, Russellville, with a Bachelor of Science degree in Health Information Management and is a registered Health Information Administrator. Jennifer Goins is a member of BKD's Healthcare Performance Advisory Services Division. She has more than 16 years experience, including 12 years at 2 academic medical centers. Prior to joining BKD, she provided management and oversight for denials management department at an academic medical center and increased appeal success rates with an emphasis on denial reduction. Jen also has experience as a charge master manager at an academic medical center where she oversaw the analysis, maintenance, pricing, and electronic medical record build with a focus on clinical and revenue cycle integration. Most recently, Jen has assisted clients with charge master reviews regarding compliance and completeness, professional claim coding reviews, and internal audits regarding denials management processes. She has provided several presentations regarding coding and charging compliance impacts, as well as preparation for the Ohio Medicaid conversion to enhanced ambulatory patient groups. She is a member of the Healthcare Financial Management Association and American Health Information Management Association and is a registered Health Information Administrator. Jen is a graduate of Indiana University, Purdue University, Indianapolis, with a Bachelor of Science degree in Health Information Management and a graduate of the Ohio State University, Columbus, with a master's degree in Health Administration. On that, I'd like to say welcome to Paula and Jen. Thank you for joining us. And Jen, if you're there, I'll hand it over to you first.
Great. Thank you very much, Andrew. I appreciate the introduction. I kind of had to laugh. I'm like, yes, it is the Ohio State University. So we'll go ahead and get started. So today we're going to talk about finding the value in your revenue cycle, and I'm going to go over several different areas first, and then I will turn it over to Paula, who's going to touch on some of the clinical documentation improvement, and then go through the end of our presentation. I do want to say, if you have a question, feel free to enter it in the chat box. We're going to try to monitor that throughout our presentation and kind of answer those questions as we go. I believe Andrew also mentioned you could unmute your line if you would like to talk and let everyone else hear your voice. I think that's a star too if you want to do that as well to ask a question. So either way will work for us. So we will go ahead and get started. So today, our agenda, what we're going to focus on today is we're going to go through the Revenue Cycle Management Guide that BKD had partnered with the National Rural Health Resource Center to do, and the Delta grant version of that to do the update to that revenue cycle guide. So I'm going to talk for a while about some of the information you're going to find in there, why some of that's important. We're also going to talk about the clinically integrated revenue cycle, kind of what that means, who's involved in it, how does that function, and give you some information around that. And then Paula's going to wrap up with talking about some of the key performance indicators or KPIs for your revenue cycle. So those, I think, are very helpful that you can use within your facility as kind of your goals, your annual goals. If you're doing if you're really close to some of these KPIs, they can be used, kind of as stretch goals for your team. And if you're kind of far off the mark, I think it's a good place to start and kind of give you an idea of maybe where you need to have some improvement. So those are kind of the three big areas we're going to focus on today. So this slide here, this is from the Revenue Cycle Management Guide, and this is kind of some of this is pulled from the website or pulled from that guide to indicate that this was done by a partnership with BKD, and as I mentioned, the National Rural Health Resource Center. And then over on the right, which I find it a little hard to read, which is probably why we missed a little typo. Believe me, there is not 200 pages in this revenue cycle guide. There's a couple of the patient registration and admissions, revenue integrity, and the clinical documentation integrity. For some reason, when this is copied over, the last digit was added again. So that's really just 13, 15, and 20. So these are kind of some of the sections that we have here. BKD, several members of the BKD Healthcare Performance Advisory Services team was involved in reviewing and adding information to the guide. All of the sections have been reviewed and updated and refreshed. We've also added several new sections here, some of which Paul and I are going to discuss today, kind of call some of those out and kind of introduce you to those sections. There's a few tables and charts that are included in this guide, and then one of the really good things I think that we've added in here is there are hyperlinks throughout this document that will allow you to click on the link and take you to the online reference or additional information based on something that is being discussed in that section of the manual. So I always find that to be very helpful when if I'm reading some sort of guidance to have, a point or a reference to, a Medicare citation or a MedLearn Matter article or something that can give me, additional information so I can read more about the topic. So here's some of the sections, the new sections that we've added. So we have added a section on revenue integrity. And really what revenue integrity kind of as summarized or defined is, it's the processes and the activities and the departments and their actions that reinforce compliant charge capture and complete and accurate documentation and prompt appropriate payment. So that's kind of a very lofty kind of definition, a very lofty kind of goal, but it's really having a group of people. You could have your own department within your facility that is the revenue integrity department, but it really is an area and where the focus is, and it's also at times can be a cultural shift too. To really focus on what the activities are, what those processes are, to make sure that your documentation is accurate, that your charging is based on your accurate and complete documentation, and then the payment follows, that it is prompt and appropriate for the services that were charged and that were ultimately documented and provided. So it's kind of like a linear little thought there on how you kind of start with that documentation and follow all the way through to the payment side. We've also added a section regarding charge capture and coding, and kind of fleshing this out more about the importance of charge capture, why you need good charge capture practices and policies and procedures, which can also include, charge reconciliation to validate that you are actually capturing all of those charges for services that were provided, and then how the coding goes along. And the coding can be, a lot of times when we say coding, some people just think, well, that's what the coding that HIM does. That is very true. HIM is going to be assigning your ICD-10 diagnosis codes. They're also going to assign ICD-10 procedure codes for your inpatients, and making sure you have an accurate and appropriate DRG or MS-DRG or kind of whatever reimbursement methodology there. But there's also coding that happens within your charge master. So within that charge master, you have CPT codes and HCPCS codes that are linked to charges. So not only is it charging, when you post one of those, it's also coding. So you're also kind of indicating that this is the service, and you're applying specific code. So this kind of outlines the importance and kind of those processes that are necessary to have really good charge capture and that kind of integrated coding. And you can't do one without the other. Coding does need to be included and understand about charge capture processes and what charges are available or not available within your CDM and within specific departments. And then we will be talking about, and actually Paula will be talking about the clinical documentation and integrity. And this can also be called CDI. And what this focus is, I won't steal Paula's thunder, but I will mention that CDI functions can be both inpatient and outpatient, and she's going to talk more about that kind of what that entails, setting up a department such as clinical documentation and integrity, and kind of how that facilitates and works with others within the hospital. And then Paula is also going to talk about utilization care management and kind of what the functions are and what the importance is for those processes within your facility. And then she's going to talk about something that I find super exciting is telehealth. So some of this seems to be the big buzzword and kind of what's kind of on the cutting edge with services and how to provide those to patients in a easier setting for both the clinician and for the patient as well. And then some kind of new things that are coming out regarding telehealth. And then she's also going to wrap up talking about the importance of having a compliance program and having a compliance department and what your facility's compliance program is and how that's going to be followed. So there's a few more interesting things that she'll be talking about on that clinical side. So let's go back here, and we're going to touch a little bit more on the revenue integrity part of it. So when we talk about kind of how I've gone over and talked about the revenue integrity. It's really those processes and activities that various departments do to reinforce that compliant charge capture and the complete and accurate documentation and the prompt appropriate payment. So when we think about that, we're talking documentation, and we are also talking about charging and coding. So we're talking about kind of two very different processes that happen by two very different groups. So on one side, we have the clinical operations. So you have the services and the care that's being provided by the physicians, by the nursing staff, and then also looking then at the charging functions and coding functions. So really, it's trying to take all of that and really kind of bridging all of that together and incorporating all of that and making sure that there's really it's kind of like having a clinical revenue cycle where there is involvement on the clinical side, on the revenue cycle side, on the revenue cycle side to the clinical side, and that everybody kind of understands the goals of the facility, and then also really what the goals are on the in delivering the care to be compliant and then to support those charging and coding functions to then ultimately translate into your reimbursement there. So really, I mean, we will say this in this office, we can mean finance, we can mean, you know, kind of generally those administrative individuals that work not on the clinical side. And then we talk about the middle revenue cycle management. And this kind of really is where a lot of revenue integrity focus can happen. While there is still important processes that are required on the front end from like scheduling and prior authorization and getting registration and then on the back end to get things built and to do follow-up to get your payment. While those are very important, kind of the meat of revenue integrity really happens in that middle revenue cycle kind of environment. So this is areas where you're going to be talking about your CDM team, where you're, again, as I've mentioned, charge capture is going to be happening. And again, charge capture, if you think about it, can really happen on the clinical side. It could be that a nurse performs a bedside procedure and then needs to enter a charge on a charge ticket or in your EMR, however those charges are captured. Or it could be that you have a team that maybe is a mix of that's within your revenue integrity department or sits within your CDM. That could be a mix of former nurses and your CDM staff that could be doing reviewing documentation and charge entry for like infusions and injections. So when we say charge capture, there's a multitude of ways that charge capture can happen. So it would be that function, and then your charge reconciliation. And this is really looking at making sure that you have captured all of the charges for a time frame, for the previous day, for the previous week or month, and kind of monitoring that and making sure that you're looking at your revenue and usage reports, and you're comparing that back to your census or your schedule, and kind of carrying out those various functions to make sure that you have captured and kind of reconciled your charges there. And then also that clinical documentation integrity. That's really going through and making sure that you have a clinical and rev cycle-minded person that is making sure that the documentation is there and is clear to get a correct code, a correct diagnosis code, or correct CPT code, kind of how whatever setting that is in. And then that utilization care management, that's really happening when the patients come into the hospital and the determination is, trying to make, should this patient be statused as an observation patient? Should this patient be admitted as an inpatient? And kind of going through that process, having those conversations with the physicians and making sure that the patient is status appropriately to receive the care, and then also the corresponding reimbursement to go along with it. So it's kind of a lot of those functions that all kind of occur right there in really the middle revenue cycle while the patient, a lot of times is there or has just recently, been to your facility. And then ultimately it's compliance and really compliance. I mean, it's being accountable, having accountability for the services that are being provided, the documentation that you're charging appropriately. It's really doing the right thing and making sure that what you have, the services and the supplies and items you've provided, and then are linked up with appropriate charges and appropriate reimbursement. So we will move on to our next slide. So let's talk a little bit more about charge capture and coding, and talk about this specifically in the context of rural hospitals. And this is an area that both Paul and I have seen where there can be a lot of performance improvement opportunities in rural hospitals around charge capture and coding. And some of the areas that we want to specifically focus on would be regarding nursing documentation that is occurring in observation, status, and or the emergency room. And then we also want to talk about the emergency room evaluation and management services that are for the facility level service that is provided. So don't feel bad if this is an area you might struggle with, or as you've listened to the rest of this webinar, kind of have some aha moments or some light bulb moments go off. Don't feel bad. I feel like we should all be looking for areas for improvement, and constant improvement is a good thing. So some of you may take a lot of things away from this. Maybe some of you will just take a little sliver of information, and I think that's great, because anything that you can take to look at these areas kind of with a different focus to be able to provide some improvement is always a good thing. So let's talk about nursing documentation. So this can happen really in observation and or the emergency department. And so a lot of times where charges are missed, or where there's issues with documentation, where maybe you can't fully support posting charges or capturing charges for services rendered, would be really in the infusion and injections. So I know, reviewing lots and lots and lots of ED records, a lot of patients come in and they're getting some form of an infusion or an injection of some type, pain medicine, hydration, anti-nausea medication, something of that nature. So this is an area where it is allowable that you can bill separately for infusions and injections in both the emergency room or emergency department setting as well as observation. A couple of really key high-level points here is that you need probably the number one most important thing, or these are kind of code number one important things, would be absolutely need medical necessity documented to justify the reasoning behind giving those medications and those infusions. Depending on what they are, there could be payer policies or local coverage determinations from Medicare around some of those infusions, especially hydration. I've worked a lot with the Novitas LCD and know there is specific medical necessity criteria for hydration for that MAC. So it's definitely that medical necessity, which kind of then falls back. Keep in mind our revenue integrity to having accurate and complete clinical documentation. And then the second kind of code number one issue for injections and infusions is really capturing the start and stop times. These codes are time-based, and they require that time to be documented. Again, that Novitas LCD does have information in it that does indicate start and stop times absolutely have to be documented. So those are two areas right there. If you know this is problematic in your area and you want to, and you're not fully charging for infusions and injections, this is definitely an area that you can work on with clinical documentation improvement or your CDM, kind of whatever you're going to have to roll up under that revenue integrity to try to get that documentation to allow you to be able to capture those charges. Additionally, we would say bedside procedures. Again, this is another area we see commonly, like Foley catheter insertions. Potentially, some facilities will do like a bedside thoracentesis, wound care, anything like that nursing is involved with and is providing those services. Those are always services that you can look at and would be separately billable for observation and emergency department kind of settings. So definitely, if you're not currently capturing those, that would be an area you could talk to your nursing staff, find out how frequently they're doing those. Take a look through a chart. Where's the documentation? Is it sufficient enough to support adding those charges to that area? How are you going to do the education and training so that the charge entry staff know to look for the documentation and then capture those charges? As you can see, that other bullet, the infusion documentation start and stop times, is so important. Not only did I talk about it, but we also put it on this slide as well. I can't say it again enough. Infusions and injections, whether you're doing them in the observation or emergency department, or if you have an infusion specific location that does like outpatient infusions for chemotherapy or for non-chemo drugs. Either way, that start and stop time is imperative to have to really support and having your documentation and making sure it's compliant for charging. And then again, those nursing interventions in the emergency room. So let's talk a little bit more about that, because as I had mentioned before, some of the bedside procedures like a Foley cath insertion. Well, when you talk about the emergency room and kind of the nursing interventions that can occur there, I'm not talking about specifically a full-on procedure that a physician's doing, but I'm talking about things that the nurse may be assisting the physician with. If that nurse is assisting with a laceration repair, if that nurse is doing a Foley catheter insertion, if that nurse is also, assisting in the casting of a fracture, those are all documentation elements that you want to be looking for to support charging for that, because if that nurse is assisting or doing some of those interventions in the ED, then, and you're not charging for it, you're losing out on kind of accurately reflecting your cost and the resource consumption that patients have while they're in your ER. So that would be another area I would say might be worthy to take a look through some of your ER records and documentation. Talk to the nurses, the nursing staff, nursing manager that's in the ER. What's eating up a lot of your nurses' time? What are some of those interventions they're doing? And do you have appropriate charges that you could charge for them? And are those available? And are they educated on to know when they can charge for those? So we're going to keep talking about the ER here, and this focus here is, and it kind of carries over from those nursing interventions. So let's kind of hold the nursing interventions on the back burner for a second and let me get you kind of oriented to this slide. So whenever Paula or I work with a client and look at kind of their ER charging structure, the thing we always do is we always graph out what their distribution is for those 5 ED levels. Now remember, this is on the facility side. So this is not what the physician has billed. This is what the hospital or the facility has billed for the services that they've provided in the emergency room. Now, if we remember what the kind of the rules are around emergency room E&M service billing, is that, excuse me, the physicians are held to following the CPT descriptions and criteria that are outlined in the CPT code book, whereas facilities are allowed to develop their own criteria for how they are going to determine that the services they've provided fall into each one of these 5 levels for an emergency room evaluation and management service. So that definitely means, number one, you need to have your criteria documented. So we have seen it could be a point structure, it could be different categories of interventions and services that are being provided that get you stepped up into, a level 3, and then if you have these 2 other items done, that may move you to a level 4. So number one, if your facility doesn't have criteria like this written down, that would be imperative, is that you have some sort of document available that guides charge capture individuals on how to assign these. And then number 2 would be definitely somebody needs to be monitoring this distribution at least monthly. If not, I guess I should say worst case quarterly, but I would recommend at least looking at it monthly. So you want to see what this distribution is telling you. So in this example here that we have on this slide 8, we can see that the distribution is shifted to the left, which means the 99283, which is a level 3, which is right in the middle, we have a higher distribution to the left and a lower distribution to the right of that. So what this, if Paula or I saw this, this would be concerning that a facility could be undercoding or undercharging their ED visits. And this would be, we would want to look at that criteria to see, you know, what does the hospital look for in the documentation to really determine which level that they're going to assign for that visit. And are we missing, is someone missing the documentation and undercoding here? Or are we not capturing all of the documentation to really allow the charge capture individual to look at the documentation and assign the appropriate code? So more than likely what we would say here is there's probably a decent amount of level 2s that should be converted to a level 3. And then there's probably a decent amount of level 3s that could go to 4 and maybe a few 4s that could move into level 5. Now, a couple of other things that I want to point out with this graph, and then I'm going to circle back and talk about the nursing interventions here, is when you look at this, you want to look at this distribution for all charges and all patient types. So you want to include your patients that go to inpatient, because your level 4s and 5s are probably going to make up a high portion of those patients that are placed in as inpatients or could be converted to observation. Additionally, your level 4s and 5s could also be patients who stay in outpatient but are transferred to another facility for a higher level of care. So you want to make sure you don't artificially move this because you're not fully looking at all of the charges and the charge distribution for all the patients that you're caring for. So, so that I just want to make sure that that's clear. Another thing is if you do have physicians, you know, a physician practice or an ED practice, if you look at their distribution, it should not marry up to what the facility distribution side is. Their distribution is going to look much different than what the facility's distribution is. So I know I've definitely seen it once, at least one facility where they matched completely, and that was just due to a process that they had one person entering, determining the level on the physician side, and the hospital just did the same level. So again, I would say I would kind of caution you away from that and make sure that your facility has those criteria for how you want to or how you determine these levels, and then that's the criteria that you would use to assign the charge to. Now, let's go back to those nursing interventions. So if you're kind of lost sitting here going, well, I'm not quite sure how I would have the documentation to kind of move this up from a level 2 to a level 3. And that's really where it's great to have those conversations with your nursing management in the emergency room to say, you know, what are the nurses doing that's taking up a lot of their time that isn't really separately billable? And it could be that maybe your facility has a criteria that if a patient comes in and has suffered a head trauma, they've had a fall, they've hit their head, you know, they were in an automobile accident and their head cracked the windshield, something like that, and that patient needs to go to have a CT scan done. If your facility requires that patient to be accompanied by a nurse, then that would be something that would be a nursing intervention that is, there is no separate charge or CPT code for that, but would be something you would want to consider to include in your E&M service. So if your nursing staff is leaving the ER to transport the patient to radiology and wait on them while they're having their CT scan to then transport them back, they're not available to care for anyone else during that time. They're not available to do another chargeable procedure or chargeable service. So that's something that you want to make sure that that is clear in the documentation, and then gets captured with your point system or with your criteria. Additionally, as I was mentioning before, if that nurse is assisting a physician with services, then that could be something that you may need to look at as well, whether that's separately charged or whether that needs to be included in here in your E&M service charge. So really lots of areas. There's always a lot around the emergency room. It's a busy place. It's a hectic place. That you want to make sure that you're getting good, clear documentation that will translate to your charges, whether that is a separately identifiable procedure or if those services get rolled up into this emergency room E&M service that would be billed. And then lastly, I just want to say, I know there's been lots of news recently within, I'd say, the past year or so about payers coming back and looking at and automatically downgrading level 4 and level 5 ED visits. Don't take that fear and automatically just downgrade and downcode your services for fear that somebody might deny you or try to downgrade your ED visit. What I would say is monitoring these reports on a monthly basis, knowing what types of patients are falling into your 4s and 5s, if they're primarily those patients that are being converted to observation, inpatient, or are transferred. I think you've probably got a solid case for an appeal and for an argument that why it needs to stay a level 4 or level 5. However, if you find that a lot of your level 4s and level 5s are for more simple procedures like a laceration repair or something very minimal, then I would be a bit more concerned, and I would recommend there needs to be more focus on how your levels are being, your ED levels are being assigned based on that documentation, and how you're getting some of those kind of less acute patients into a level 4 or level 5. So with that, I am going to turn it over to Paula, who's going to continue, I believe, talking about clinical documentation improvement now.
Thank you, Jennifer. And I'd like to just open it up right now. We haven't had any questions for the chat room yet. If you would like to, please do ask us questions. We'd be happy to address those during this session. And also, you're more than welcome to hit *2 to unmute your phone and to talk to us directly and ask questions. We would really love to hear from you if you have any. So I'm going to move on now to our next slide, which is clinical documentation integrity. And we talk more about this, or we discussed this, or it's documented more on page 21 of the Revenue Cycle Guide. This is a new area that we wanted to focus on because we do feel like this is important. Since the inception of ICD-10 in October of 2015, we are seeing more and more hospitals reinvigorating their CDI programs if they have one. CDI has been around for many years, and you think about it, back in the day, for DRGs, it was to really capture the most reimbursement that you could through your comorbid and complications, those conditions. But today it's more focused on quality and also moving into a fee-for-service environment. We are now mainly seeing CDI programs in the PPS hospitals, but we are also seeing a trend that critical access hospitals are now developing CDI programs. And also this is due to an increase in inpatient medical necessity denials. And it's not just from Medicare. You know that Medicare will, presume that they're medically necessary if they have met the 2 midnights. But we have seen many payers, and I would say including Medicare Advantage, that are downgrading inpatient admissions to observation services for both the small rural PPS hospitals as well as the critical access hospitals. And then Jen did mention previously about outpatient CDI. And you think about it for the small PPS hospitals that have orthopedic services, Medicare has taken the knee and hip replacements off of the inpatient-only list. And most recently, it was, the hip replacements this year, starting this year. And I'd like to say that, with a clinical documentation integrity program, Andrew, I guess we'll just turn it over to you.
Alrighty, thank you so much. So before we leave, I just have a quick polling question to assess knowledge gain after the webinar, and I'd just like to thank you, Jen and Paula, again for presenting. So yeah, before you log off, you could answer that polling question. That would be great. And this recording will be available on our Help Webinar playback page shortly. And also on that slide, you'll see that short online assessment. Completion of that assessment is necessary if you want to receive one ACHE qualified education credit for today's webinar. And also use the links on that slide as well to assess our large array of resources, including upcoming help webinars. So if you have any questions or comments, please do not hesitate to reach out. I'll post my email in the comment box. But other than that, I'd like to thank everyone for participating. Jen and Paula, again, thank you for presenting, and have a good day, everyone.
This conference is no longer being recorded.